2/3. So they couldn't find any difference in the composite outcome of death or neurodevelopment disability and was associated with a trend toward more hypoglycemia if you restrict the fluid. So the main thing is that tailor your fluid to each baby avoiding hypoglycemia. We are starting the fluid from 50 to 60 ml per kg per day on those babies, and then we will see, because the chances of inappropriate ADH can be there. So you have to maintain, you have to see the sodium and everything. Then it's a chance, then is the seizure management, which is very easy. Just put, if you have a seizures, please, again, we have a debate on the academic neonatology, the phenobarb, the phenobarb, the phenobarb. You don't have to have any cap of this thing. Phenobarb is still the recommended choice of the first line. The International Legion and on anti-epilepsy, International League of Anti-Epilepsy classification, that the diagnosis of seizures in the neonate relies on EEG. So if you have the AED or EED, that's fine. You put the baby on that, but you know how to interpret that, and then you will be better off. But the phenobarb is still the recommended choice. It's the load with 20 milligram per kg and then 5 milligram per kg after maintenance dose. Now, so put a cooling aside, but if you are intubating the patient, we need some sort of the sedation. Why? Because if the baby become agitated and baby is not comfortable or having a pain, then the metabolism is start going up. The whole idea of the cooling is that to decrease the metabolism, to conserve the energy as much as possible, and to reduce the anti-inflammatory agents. So the best medicine is the morphine, 50 microgram per kg, followed by the 5 microgram per kg per hour. It's the most evidence. Should avoid benzodiazepines because benzodiazepines are a very potent respiratory cause a respiratory depression. So avoid midazolam and all those stuff. Just give the morphine. There's a new medicine called dexamethasone, which is also people are using, but if you combine with the hypothermia, let's say the adverse CVS even in the piglet model, despite the pharmacokinetic levels within sedative range. So don't go into the thing. This is just for FYI, for your information, but just stick basic to the morphine. Come to the basic laboratory test. Blood gas analysis, you have to have it, complete blood count, glucose, as I told you, kidney function, as I told you, BUN and serum creatinine levels and electrolytes. At least the baseline liver function test, you should have it, and the cardiac evaluation, if you have the electrocardiography or echo, then it is perfect. Infection, you'd have to draw the blood culture and start those babies on antibiotics because we don't know. Maybe this infection, because the incidence of infection in our country is very, very high. C-reactive protein, you want to do it, it's up to you, but it is no value at that point. Although cerebral spinal fluid, but the babies are so sick at that time. I mean, everybody is avoiding to do the CSF, but later on you can do it. Cranial ultrasound, if it's available, you can do initially and then after 24 hours. Radiograph, you can do abdominal ultrasound. Some people recommend, some people not at the time, but because of the hepatic injuries and adrenal hemorrhage, they are doing it. Coagulation study, yes, we are sending the baseline coagulation studies in all those babies to see the PT, PTT, and inborn errors of metabolism, of course. We have to find the cause that why the baby is hypoxic, and inborn error of metabolism is very high on list. How we monitor our nursing, allied health, and interprofessional team. Cardiovascular, as I told you, monitor blood pressure, heart rate, and perfusion status. You have to examine every hour for the next, or every 2 hours for the next 12 hours. I will show you just in a minute the table. Monitor continuous mean arterial pressure and preferably is the invasive. You have to have arterial lines, obtain full EKG if there is a significant bradycardia, and consider an echocardiogram. Respiratory, if the baby is ventilated, try to minimize it so the baby shouldn't have hypocarbia or the hypercarbia. Again, this is the basic thing, the last point. If you want to invest in something, find the humidifier and heated gas. You cannot do without these things. So blenders, humidified and heated gases is much needed as compared to any other equipment. Fluid and electrolyte, we already discussed neonate, preferably are kept nil per oral, but we are starting, if the breast milk is available, you can call it non-nutritive priming or the trophic feeding, but we are doing the trophic feeding. And if the neonate has adequate urine output and normal liver function, of course, we have to see these two. Then overloading the fluid, maintain glucose level, a syndrome of SIADH or inappropriate antidiuretic hormone secretion is also common after perinatal asphyxia. So much watch it and keep your sodium levels, keep an eye on the sodium levels. Neurological is the most important. NA needs frequent exam. The neonatal asphyxia needs frequent exam. Monitor the pain. Watch for the over-sedation due to the possible accumulation. Commence AED monitoring if you have it. Consider brain MRI. We discussed in the last Saturday at 4 to 7 days of life after the neonate has this insult. Come to the other therapies. There are 4 therapies I'm going to talk about. First is the magnesium, and there is a reason for that. Magnesium sulfate is the N-methyl D-aspartate receptor antagonist, which is the excitotoxic this receptor. So it helps in reducing the excitotoxicity. So these are the primary energy failures, minutes, hours, days, and these are the therapies. So if you are doing hypothermia, you have to start within 6 hours. Seizure management, as soon as you notice there is seizures. Neuroprotection bundle, which we just talked about, as soon as you get the baby. Erythropoietin, and then melatonin and magnesium sulfate you can start. So melatonin, why I put it, I will show you in a minute. Free radical scavenger, anti-inflammatory, anti-apoptic, receptor-mediated gene regulation. Erythropoietin, it modulates inflammation, angiogenesis, and neurogenesis. The last but not the least is the stem cells, but still they are doing. There is a study going on in the lens, they are giving the stem cells through the nose. It passes through the cribriform plates, and they found it out, this thing, but it is just a study. Forget about the stem cell. So the first drug is erythropoietin. Unfortunately, after the successful trials, we get the results of HEAL trial last year, July 2022, and it says that administration of erythropoietin to newborn undergoing therapeutic hypothermia for hypoxic ischemic encephalopathy did not result in lower risk of death or neurodevelopment impairment than placebo and was associated with higher rate of serious evidence. This last sentence is associated with serious adverse event. Those who are not using the therapeutic hypothermia is also going away from erythropoietin. So the erythropoietin is, after these results, are not very recommended in encephalopathy. There are many other medicines, but we will not go through it. There are a lot of trials going on. But first, we will talk about melatonin. The melatonin is secreted from the pineal gland of the brain. It is indolamine hormone that it works with the catecholamines. It is the what you call calming hormone, like serotonin is another indolamine, is a strong safety profile, its ability to cross the blood-brain barrier, and diverse protective properties. You know that the melatonin is good for the jet lag. If you're traveling across the Atlantic or coming back from there, you have a jet lag on both sides. So because of that, the melatonin is very nice. During the darkness period, the melatonin goes up. Okay, so in the saliva, it is also goes up. In the plasma, it's very high. And then so it's from like, let's say, Isha or Maghrib time to Fajr time, its level is high. So that's why it is very good, because it when you have a jet lag, you have a, let's say you going to USA and there is a daytime and is already night. So you are going to sleep at that time. So they adjust your melatonin level and help in this your sleep jet lag. How it neuroprotective is a free radical scavenger. It is a very strong free radical scavenger and it preserves the mitochondria integrity. It is anti-apoptotic receptor mediated gene regulation. It is these are the four mode of action. There are many studies about that. I will show you at what point we are. Clinical trials in the baby is a small number, and the pharmacokinetics we don't know yet. Adequately powered clinical trials are needed. So these are the melatonin efficacy assessment. So first thing in the lab, it dose-dependent reduction in cell death, they found it out. Then in the rats, more than 50 studies showing dose-related response and proof of concept. Then they took the piglet model and the sheep model plus minus cooling, as you can see in this diagram, and they found it out that how it is going. This efficacy is there. In the babies is a very small trial, only 10 babies, and no consistent endpoint, no pharmacokinetics, oral administration, systematic reviews we don't have, so we don't have yet its efficacy. So as I mentioned here, systematic review and the meta-analysis of the Pang and his colleagues, it covers from here up till here. This is in the humans. So it include all the studies, which is the piglet model, sheep model, or the rat model, or in the lab. And they found it out, the melatonin in the brain infarct size is melatonin is helpful, neurobehavioral outcome is helpful, histology at cell death is helpful. But the problem with this meta-analysis is the heterogeneity. Let's say it's the 58% here and 33% here. Similarly, for our topic, that if you are not cooling the baby, if normothermia, the efficacy is still there. But again, the heterogeneity of all those studies are very high, which is 67%. If you are using with hypothermia, still the heterogeneity is high and the effect in favor of melatonin. So to answer all those questions, the Acumen study is going on in University of California, acute high-dose melatonin for encephalopathy of the newborn phase 1 dose escalation and cohort expansion study. This is the chemical thing, and this is the how they act, and this is the study. If you are interested, you can see, and this is the, we are waiting for their result. Magnesium sulfate, I told you how it works. It is a prospective longitudinal trial that show that without hypothermia therapy effect, but some are saying that because of the high dose, if you use them, the chances of hypotension and bradycardia, but meta-analysis of 5 small trials shows no side effects. So it's used in the low cost and ease delivery. Magnesium sulfate is considered a potential viable therapy in our setting, which is the low resource setting. Now I give you the evidence. So one good article written by, as a father author by Professor Haq, he already shared with you. The another from Pakistan is by Dr. Tayyaba Khawar. He's, I think, working somewhere else. She did the study in 2021, published magnesium sulfate is better in establishing earlier suck feed and reducing the duration of seizures. Then Dr. Puratulan is also our in our academic group. They published in 22 Jan that if you combine the magnesium sulfate to the melatonin, then what will happen? Then of course it has a good result. Another study from the King Edward Medical Group, College Group in August 2018, the role of melatonin in management of hypoxic ischemic therapy, and they found also the good results. So there are few things which you can do without the hypothermia. So let's say that we don't want to do the hypothermia. So we have to categorize whether it is severe or not. If it is mild, that or it is severe. If it is mild, that assess at 5 minutes and assess sensorium and tone. If it is normal, then no need to the abnormal, then go to the next chart. Then requiring the back and mask ventilation or the neopuff for more than 60 seconds, then check the vitals, and then do the same thing. The neuroprotective bundle, acute neuroprotective bundle. Maintain the normal temperature, maintain oxygenation, maintain normal perfusion, maintain normal blood glucose, watch for seizures. No encephalopathy. If the baby is fine, shift to the breastfeeding, and that's it, and follow up. And moderate or severe insult, then of course, what we did, restrict the fluid to about 50 to 60, monitor vital signs, monitor the urine output, monitor the blood pressure, initiate intragastric tube feeding initially, and then see if the suck and swallow reflex are there or not. Assess for sepsis, and the baby does not improve. If no improvement or deterioration, you have to make a checklist. So from the SaveNet scoring, we put it like this, that in our documentation, the mild, moderate, and severe. And how you document it, that you have a science. This is the temperature, color, capillary fill time, oxygen saturation, urine output, and neurological exam panel, unconscious tone, seizure, sucking, and respiration at admission, 2 hours, 4 hours, 6 hours. So initially 24 hours, every 2 hours we needed to examine the baby. Last 2-3 slides, practice points. We cannot do the cooling, or it is not recommended. We can debate whole night. But this article said that therapeutic hypothermia alongside optimal supportive care increases mortality and does not provide neuroprotection. So what they suggest? Meticulous attention to supportive care, what we just discussed, avoidance of hyperthermia, hyperoxia, hypocarbia, hypoglycemia, hyperglycemia, appropriate seizure management remain the most important steps to reduce brain injury. So just focus on that instead of doing something. So clinical cooling should adhere to the established. If you want to do that, I will show you in the next slide what to do, only for moderate or severe encephalopathy if you want to do it. The other thing, I don't know, Dr. Sajjad is very pro into it, but we don't recommend in our periphery here in the UAE also, with who cannot do the cooling. And also in the USA, let's say we have a centers which they feed us with those babies. We don't recommend, ice and gel packs, especially for Pakistan. We cannot do that. We don't have the training for that. We cannot maintain the temperature. Where you put the temperature probe, our nursing is not trained for that. So inexpensive manual cooling methods such as ice and gel require close nursing monitoring to maintain core temperature within the target place is limiting its use in our low middle income countries. This is the article published by Dr. Sita Sankaran and Professor Zulfikar Bhutta is also the part of it. After having all this, if you want to practice the therapeutic hypothermia, so these are the 4 things you have to answer. What is the current practice? Yes, in the high income countries, this is the current practice. best practice guidelines, care pathway. Neonate with encephalopathy should be quickly identified, transferred to a center where you can do, not all the centers can do the cooling, where you can manage the multi-organ failure, neurological complication, and therapeutic hypothermia. Careful attention to basic physiology, use of strict protocols. So these are the criteria and protocol. These are not the guideline. We cannot change it. Early recognition and treatment, management by an experienced multidisciplinary neurocritical care team in a dedicated referral unit. So the major recommendation, establish an experienced team of all the neonatologists, neurologists, bedside nurses to manage units. When we started here in UAE, we send our nurses, we send our doctors, and then we get all the training, and then we will be started. Establish guideline to manage implementation of TA. This is from the Newborn Brain Society, and if you want to do it, then of course the do's during the therapeutic hypothermia and don'ts during the therapeutic hypothermia, you have to have very well trained in that. Otherwise, you can harm the baby. So summary is the lung aeration is critical, delayed cord clamping is the recommended, or the cord milking, we don't have the answer. Neuroprotective role of optimizing glucose hemostasis and nutrition, avoid hypercarbia, hypocarbia, serial echo helpful. If not available, then of course the invasive monitoring of the BP. Parental involvement in care and holding is very important. So you can give the low dose morphine, and systemic restriction of sodium and fluids, and look for the seizures and a present load with the phenobarb. Serial neuro exam is must in this condition. With that, I took a little bit over time, but I think I want to cover as much as possible. I hope you all get some information that how to deal with these patients. Thank you very much. Thanks a lot.
Thank you so much, sir, for a wonderful presentation. So we have a few questions. Should I start?
Sure. Yeah, sure. Why not? Hello.
Yes, sir. So here is one question. In terms of milrinone, in the context of HIE with PPHN and AKI, is milrinone recommended? If yes, would it be wise to reduce dose of milrinone, as milrinone has renal excretion?
Okay, so it depends how is the extent of an AKI or the kidney injury. If that is not that much, we recommend to have a creatinine level 90 and below. If it is more than 100 and above, then of course you have to reduce. If you have no other way you can control and you have to use the milrinone, then you start with the low dose and then see the effect, and then you have to monitor it. So answer is yes. Okay, the milrinone is a very helpful drug, but it has the side effect like any other drug. If you have a problem with the kidney injury, you can reduce the dose, but just see how the extent of the kidney injury.
Right. So another question is, moreover, in terms sildenafil use in HIE, if LFTs are deranged, one should be cautious in using higher doses of sildenafil, as excretion is mainly through liver.
I don't think so. The LFTs has that much deranged by the sildenafil. Okay, the dose is not that high of the sildenafil in these cases, so I think you can use pretty well. There's no problem in that.
Right. So another question is, if seizures not controlled with phenobarbital, then next drug,
Okay,
what
sure.
is next drug?
Exactly. The next drug is the same. The phenobarb is the first one. The next drug either is the phenytoin or the Capra, levetiracetam. You can use either one, but the first line is always the phenobarb. The problem is that many people are using Capra as the first line, which is not recommended. Still, we get in our neonatology conference about the neonatal seizures due to the encephalopathy, and they still recommend is the phenobab. So after that, you can use either the Capra or the phenytoin. It's up to you, whatever is available to you.
Right. So if seizures are not control, if seizures are controlled on the anticonvulsants and baby is stable, for till how long we use anticonvulsant? Do we stop or continue?
Oh, no. So let's say you start the phenobab, the seizures are controlled, okay?
Right, sir.
Then is the thing that you have to have the EEG, the proper EEG, and see the pattern. If it is not very much deranged, if it is normal, then of course you can decrease the phenobab and ultimately discontinue. But if you have the problem in the EEG, then you should continue. Many times it happens that we have some problem, then it's continue with our neurologist, and they continue for 1 month to 3 months, and then they stop it when they find the EEG pattern is good. So we have to have a proper, not the AEG, but the proper EEG before we decide about the anticonvulsant therapy to be stopped.
Right, sir. So, another question is, what is difference between the passive and active cooling?
Okay, this we discussed last time. The passive cooling means that you just switch off everything, the incubator temperature, and all the what you call the warmer and all these things. So it's just a passive cooling, and it is many of the centers using for transferring the baby from one center to another center where the proper cooling is available. Active cooling is through the machine, through the ice gel packs or the ice packs, is through the actively decreasing the temperature. So this is the main difference, that the passive and the active cooling. The passive are those that you just try to turn off the incubator and the warmer, and then keep it whatever it is. And then, of course, during passive cooling, during your transfer, you have to monitor the temperature also. It shouldn't be less than 33.5. So this is the difference between passive and active cooling.
Right, sir. Sir, another question is, why weight less than 1 point is not fit for the therapeutic hypothermia? Suppose if baby is 37 weeker, but IUGR weight is 1.5, do we cool or not? And why not we cool the babies less than 35 weeker?
You tell me.
Yes, sir.
Okay, so so this is the two things. Okay, first of all, the easy answer I'll give it to you, that all the trials, okay, there is no trials. It's only recently they have some trials, but before the cooling is the standard of the care is on the babies more than 35 weeks. In fact, 36 weeks and above. So we don't know how the cooling affects the small babies. Similarly, if the baby is IUDR and 1.5 kilogram only, we don't know how the side effects, how the bad effect on the cooling. So this is we don't have the evidence in those babies, the lower weight, that how the 33.5 temperature act on their system physiologically. So that's why it is in the exclusion criteria. We are not cooling the baby.
Right, sir. Another question is, if investor BP monitoring isn't possible, how non-investor blood pressure monitoring correlate with the investor BP monitoring? Does non-investor BP helps?
Of course, nothing is better than, is better than something is better than nothing, of course. But the thing is that then you have to have a very good eye on the perfusion, on the urine output, on the blood pressure with the non-invasive method, and the capillary perfusion, and then combine together to get if this is giving you the real picture or not. You have to use appropriate cuff size. These are not very small babies, which is like 26, 28 weeker, where the cuff size is a major problem. These babies are 35, 36 weeks and above, and more than around 2 kilogram and above. So you should have a proper cuff size and then maintain it. But then, of course, you have to see the other parameters also. if you don't have the non-invasive BP.
Right,
So
sir.
see, if you don't have the non-invasive BP, but you want to cool the baby, that's very good.
Right, sir.
Okay,
Is there
good.
any role of umbilical cord blood in the treatment of birth asphyxia?
What is the meaning of that?
I don't know, sir.
I didn't get it. That the role of umbilical cord blood in treatment of birth asphyxia, you mean the stem cells or something like that to give?
I think
Yes, stem cells have a lot of role, and this is a lot, as I told you. Now there is a non-invasive method by just giving in the intranasal to through the cribriform plate. This the in the LAMS studies is going on, and they have a very good result. If this is they are asking, yes, the stem cell or the umbilical cord blood has something. They extract the stem cell and or is something else? I don't know if something else.
Right, sir.
What
Sir,
do you think?
one more. So I think, sir, she's asking the same. What I think.
Yeah. Okay.
Uh, Another question is, sir, why phenobarbital is preferred despite of side effects? Why not Lares?
What is Laris?
Sir, levetiracetam.
Oh, levetiracetam.
Yes, sir.
Okay. As I said to you before, I will answer you separately because it takes the pharmacokinetics and the physiology of the babies. We have to look into it. Okay. Especially with the baby with the neonatal encephalopathy. Okay. So we don't know how levetiracetam, okay, is have the what is the as I told you about the melatonin. We don't know the pharmacokinetics in the encephalopathic babies about the melatonin. But there are some studies I showed you from Pakistan also, they have a good result. Similarly, we know about the phenobarb, we know about his things, we can do the levels. So that is the most preferred drug, not only the encephalopathy, but any kind of a neonatal seizure. Okay.
Right, sir.
So levetiracetam is a much newer drug than phenobarb. It needs a lot of more investigation before it can come to the first line. So we continue to use as a phenobarbital.
Right, sir. So another question is there any difference in efficacy of oral versus IV phenobarbital, as IV form of phenobarbital is not available at many setups?
So this is the same answer that is something is better than nothing, but of course IV phenobarb is preferable initially in the first 24-48 hours unless you establish the feedings.
Right, sir. One more question: for how long we use magnesium sulfate in case of birth asphyxia? Does in every baby we use or only with seizures like stage 2?
So these are the two questions. What you the thing is that what you want to reduce. So if you want to reduce the brain injury due to encephalopathy, then use 3 doses, 3 days. Okay, the magnesium sulfate.
Right.
Magnesium sulfate. So, but I'm just now focus on that. That this is the thing. But every baby, no, of course not. We if you want to use, if you don't have the unit, the cooling option, we are not going to that. Then of course, any baby fit into the criteria that this baby has encephalopathy, moderate to severe, according to the SANET and your examination, which is the very important aspect of that. Then you should start the magnesium sulfate. You shouldn't wait for the seizures to start.
Right, sir. Thank you, sir. So one more question: when to get an EEG done after stabilization?
Once it is done, then if the baby has obvious seizures, start the phenobarb, just wait 24 to 48 hours and then get a proper EEG. It's not the AEG I'm talking about, the proper EEG. So at least after 48 hours.
Right, sir. When we should start maintenance anti-epileptic drugs in case of neonatal seizures? Is there any specific criteria?
As soon as you observe the seizure, as I told in the presentation, that you start with a load with the phenobarb. As soon as you have this seizures. Okay, there's no such thing that at this point you have to start. As soon as you feel that there's a baby has seizures, or if you have AEG, you can see on that, or you see the abnormal jerking movement, which we cannot stop by holding the baby, then of course you have to start the seizure.
Thank you so much, sir. I think all questions are covered, and Dr. Professor Khalid Haq and Professor Sajjad Rahman is also with us. Any comment from your
Sure.
side, sir?
I would like to thank Junaid. Junaid, excellent, absolutely excellent, marvelous lecture. I enjoyed it very much. Thank you. Thank you for it. Very nice.
Thank you, sir. Thank you for your appreciation.
Yeah, the same from me, Dr. Junaid. Excellent presentation and excellent review of everything. And the most important thing is you gave the practical things which can be done in LMIC. Thank you very much. I'm sure the attendees. Yeah, that was the idea, and you did very well. Thank you very much.
Thank you, Sajjad Bhai and Professor Haq. This is, of course, with your experience, we learned a lot from that. Anyway, I will share this thing in the PDF format in our group, and if you have any other question, you can direct thing. Then I don't want to take too much time because it's already 9:25. But if you have any quick question, anybody can go through it. I'm more than happy to answer. Yes, Saeed, go ahead.
I think the no question is here in inbox.
Sure.
So I think we most covered all questions from participants. So I would like to pay the thanks, especially Dr. Junaid Muhib Khan and Professor Khalid Haq and Professor Sajjad Rahman and Dr. Naveed Ahmad Durrani and all our senior respected teachers and as well as dear colleagues and participants. So inshallah, in next week, we will discuss another more common topic, which is approach to neonatal seizures by Dr. Raman Kumar. He is a pediatric neurologist at Liaquat National Medical University, Karachi. So inshallah, next week, we will again learn from him. So for till that, I think Allah Hafiz and take care. Once again, thank you so much.
Thank you very much. Thank you very much.
Thank you. Thank you, everybody, and thank you, Dr. Janet.
Thanks a lot.
Thank you. Assalamu alaikum.
Assalamu alaikum.